Hi everybody, it's me, Matt Simmons again, and we're here today to talk about COVID again. We thought that after a while you would like an update to see how things are going, and now that we're kind of in the thick of things, it's time to reassess where we are and look at what the next steps are. So this is an update on COVID, and we're going to talk about where do we go from here. This data is from the West Virginia Department of Health and Human Resources, and it was updated on 5/18/2020. And you can see at the time that this PowerPoint slide was made, there were 1,490 cases in the state of West Virginia, 67 deaths, 75,490 confirmed laboratory results, and that doesn't mean that they're positive, that just means the number of tests that we confirmed they're done, and a cumulative percent of positive tests of 1.97. So what does that mean for us? Well, first of all these numbers have increased, but this means that there is a slow trend towards positivity in the state of West Virginia, but the percentage of people, 1.97, is very low. Why that should reassure you is your likelihood of running into anyone with COVID and going about your daily business is relatively low based on where you are. Now, if you're in the middle of the state and you don't have any neighbors for miles and miles, that means you probably don't have a high risk of running into someone. However, if you live in the middle of Martinsburg, West Virginia, or Morgantown, your chances, based on population density, are much higher. So this number can become somewhat deceiving. I don't want you to think that that doesn't mean you're never going to run into someone with COVID, because there's a very good chance that you might. It just depends on where you are and where you're living. So the next things that we're looking at are slides of the breakdown based on race and ethnicity. So as you can see, based upon West Virginia's demographics, more than 80% of the cases of people who are positive are Caucasian or white, with African Americans making up 7.2% and other ethnicities making up 11.7 ethnicities and races. Age groups, you can see that there is a split here. You can see between the ages of 20 and 29 are 16% of the cases. 40 and 49 are 16% of the cases. 50 and 59 are 17%. And then 21% of them are 70 plus. Does that mean that the elderly are more likely to get it? Maybe, but it also might mean that these people in the younger age brackets are less likely to show symptoms, and so they don't get tested. As you probably have read or seen on the internet, a lot of asymptomatic cases exist out there, and we're not quite sure what percentage of the cases could be asymptomatic. And gender, if you look at gender is slightly skewed towards female. Why is that? Even though the virus is more likely to infect men, in the state of West Virginia, women are more likely to seek health care than men. So let's break down by county. If you look, there's some very interesting things on the slide that we need to talk about. Berkeley County here has the percentages of race by county of 11.43% of them being African American, others being 10%, and 78% being Caucasian. What's interesting about these cases is if you look, death and hospitalization are skewed in African Americans. Hospitalization seems to be that more people that are being hospitalized are African American. What does that mean for us? Well, it means that certain genetic factors that contribute to certain health risk factors for African Americans, such as hypertension, diabetes, might participate in the risk that why these people are getting sicker. And you'll probably have heard by now that there are some initiatives out there to get more African Americans tested. Why is that? Because we know that this is a population at risk, and we want to identify people who are at high risk and make sure that we identify them early and can get them to care if they need it. These are the number of counties. Breakdown in counties, you can see Berkeley County has 210 cases at that time and 6 deaths. And down here is Jefferson with 101 deaths. Kanawha County with 206 cases and 15 deaths. And these make up a lot of the most hard-hit counties in the state: Kanawha County, Berkeley County, Jefferson County, and Mon County. Now, if you look, certain counties will have cases, a lot more cases than you would think. Jackson County had 136 cases with 17 deaths. Their population density is different, and it was probably related to a healthcare facility that had an outbreak at that point. Whereas if you look at other counties like Fayette County with only 8 cases, it's probably due, again, to the difference in the demographics in Fayette County. So how sick are people that are getting sick with this? We talked about in the last lecture that we were not really sure at that time how sick a lot of people were going to be. We have a better idea now, but we still don't know the full extent based on the fact that we don't know how many people are getting sick. What factors into that is who gets treatment, who seeks testing, who gets treated presumptively because they didn't have access to a test in certain places, who is sick and makes it to the hospital and has all the standard of care, who gets to a hospital and doesn't get all the standard of care because their hospital doesn't have access to it. But what we can see is, of the cases that are active, 473, which is about 32% of the cases that we've experienced, only about 1.4% were sick enough to be on the vent, and that's pretty representative of what we saw coming out of China, somewhere between 1.5% and 2%. Those that were sick enough to be in the ICU and not vented was 0.9%, and those who were sick enough to be in the hospital on the floor were about 7.8%. So only about 10% of those cases currently are in the hospital. Those that are long-term facilities were about 26%, and those who were home were about 90%. What does that mean? It doesn't mean that sick people are not getting care. It means that most people that are sick with COVID are able to recover at home. And as you can see, of these cases, of the cases that we talked about before, about 919 of them are recovered, or 63%, with about a 4.4% fatality rate. Now, 4.4% sounds really high, or really low, depending on your understanding of epidemiology, but 4.4% is skewed here again in the fact that there's a disproportionate number of deaths in those who are elderly over the age of 70. And you can see the breakdown of these hardest hit counties again, positive cases, over 200 in Berkeley, but you see the bars are really small. You can barely see them of those people that are in the ICU, those that are in the hospital, and of course, those fatalities. The fatality bars stick out because they're black, and against the white background, they seem really big, but those numbers are relatively small, okay? And in the state of West Virginia, every single one of the 55 counties is reporting cases. If you look, the case fatality rate in West Virginia is about 4.3, and that sounds really bad, but if you look comparably to the other states, only Virginia is outperforming us in fatalities, meaning that they have a lesser amount of fatalities. Why is that? Well, it's probably because of Virginia's testing schedule and routine, which we don't really need to get into right now, but it's a very different type of testing regimen than we have. And so their numbers are not it's not comparing apples to apples for us. If you look at the percentage population in the United States average, 0.4% of the population is positive. But in West Virginia, it's 0.082%. And as you can see, that does much better than our surrounding states. This is also confounded by the fact that West Virginia has less of these huge metropolitan areas where there's a high population density. So we don't really need to pat ourselves on the back. Geography is helping us more than just about anything. One of the things we can be proud of is that the state of West Virginia is outperforming all its neighbors in the access to testing. We are testing a lot of people, and that's due to the fact that the administration of the West Virginia state government made it a priority to get people tested early on. Number one, so we could identify and try to limit exposures, and also two, because West Virginia's made it clear that that's what they wanted. They wanted more access to testing. So the university system, as well as the state government, worked together with big labs and internally to kind of get us more testing. And you can see that's really effective. And as you can see, the people that are being tested over here, the percent of positive tests is much lower in the state of West Virginia. There are a lot of factors that play into that. Who are you testing? Are you testing only high-risk people? Are you testing low-risk people? The broader number of people that you're testing who have low risk of acquiring it kind of skews your number. If you test a lot of people who don't have symptoms, a lot of people who don't have any risk factors, your numbers will look lower. So as your percentage of the population that's being tested increases, and less of those people are likely to be sick, this number of percentage positives drops. So when you look at these numbers, they actually look great. But one of the things you need to realize is, as a state with a smaller population compared to our neighboring states, these numbers are affected by the fact that we have better access to testing for a lot of people, and we have less population density, which allows us to get a lot of low-risk people tested. Now, this is a growth rate chart, and it's the West Virginia positive growth rate. As you can see, early on in the epidemic, at the end of March and early April, we had a 20% positive growth rate, and that rate has dropped off. What does that mean? Well, it means exactly what we think it means. Social distancing worked. Now, I want to take a minute to plug social distancing right now. This lecture is happening right on the eve when everything's going to open up again and everyone's going to be able to do all the things that they want to do. I just want to caution you that running off to do all these things without taking some time to consider wearing your mask, doing social distancing, could make this curve look like this in a very short period of time. All this hard work that you've done by staying home and doing social distancing can be undone very quickly with a disease that has an R0 of about 4 or 5. R0 is the ability for one person who's infected to infect other people. An R0 of 4 would mean that for every single person that you are exposed to, you make at least 4 people sick. Now, the R0 for this virus is probably somewhat less, or probably around 2%, but we need to really keep that in mind, that exponential growth happens when every single person infects at least 2 other people. So congratulate yourselves on this lower positive growth rate, but remember, it could look like this very quickly if we're not careful. This is daily infections, and this, as you can see, these are the number of confirmed infections that we have every day. What I really want to stress is this major positive curve that you see with a dip and then a repeat positive, this is the incubation period of the virus. It's normal that you'll see less cases for a period of time because as people become infected, it takes them a while for the disease process to show up. And then you have this decrease. But here, now you're beginning to see another increase in the curve. This is called social distancing fatigue. If you're familiar with the influenza of 1918, you know what happens now if we're not careful. If you're not, take a minute and Google influenza epidemic of 1918 and look at what social distancing fatigue led to in the late fall and winter of 1918. This should be concerning, and this is why I want everyone to remember that just because the state's opening back up, it doesn't mean that we don't need to continue to be careful. These are some other states' infection rates. I took the name of the states off because I don't want to necessarily put anybody on blast. So I just want to point out that you can see there's some increasing among other states in the number of cases, and that's to be expected. Not every single state took the same stance on social distancing and aggressive shutdowns as we did, and you can see a continued positive growth. Now, these numbers look really small because you're looking in the thousands of numbers, but that upward angle should be concerning. And this dotted line that you see, these are estimated infections. Well, you say, well, Matt, these confirmed infections are much lower than estimated infections. Remember, again, not everybody who's getting infected is coming to testing. There are a lot of people who, 1, don't want to know that they have it, or 2, say, I'm going to be fine, I don't need to get tested. And those are the things that are underrepresented. Also, too, you can see as testing increases, that number of expected infections decreases, and that's also because of social distancing. We talked about R0 before, and that's what I want to show you right now. R0 is the idea, it's a measure of how many people a sick person will infect. If you look at these different viruses, measles being a typical one, every single person with measles will infect 16 people. Measles is extremely contagious. But Ebola has an R0 of 2. Influenza has an R0 of 1.5. COVID has an R0 estimated of 2.5, and the numbers are still kind of settling, so we're not sure. But why that's important is when people say, oh, it's just like a bad flu, you should really pay attention, like the flu kills more people. The flu may kill more people on an average basis because it's been around more and it spreads, but also it doesn't meet the same rigorous isolation process that this did. This is much more infectious than influenza, and a 1.5 versus a 2.5 is exponential growth. And to give you an example, things like MERS, which is another coronavirus, had an R naught of 0.8, but had a mortality rate much higher. Now, why this is important is that the R naught of COVID-19 shows that for 2.5 people, and it's rounded up to 3 because really you can't have a half a person. It just takes a matter of time for one sick person with no social isolation to become hundreds of people. That's why this number, even though you're seeing a low amount of cases right now, if we back off of social distancing, if we don't wear our masks, if we don't wash our hands, even one person can spread it to hundreds of people in a matter of time. Because for every one person, they're going to infect 3, and then that 3 infects 9, and then that 9, and it just grows exponentially. So this is what we're talking about. And I just wanted to, this is a good example. If 4 people are infected with COVID, an R naught of 1.5, which is the lower end of the estimate, they would infect 6 people who would infect 9, but if the R naught is 3.5, which is the upper end, they infect 14 more who would go on to infect 49 more. This is literally within 2 weeks, an exponential growth of cases. All it takes is one sick person at a restaurant one evening to infect 4 people, and then it takes off. How long does the virus last? That's really what's important. Let's say you're going to go shopping at your local grocery store and you're like, Matt, do I need to wear a mask? Do I need to wear gloves? Do I need to wear a bodysuit? Well, the answer is probably just a mask. Gloves have their own issues, and if you wash your hands well, gloves are no substitute for just good hand washing outside of the hospital setting, okay? But in the air, it can last up to 3 hours as an aerosol. That doesn't mean that me talking, this room is going to be infected if I have COVID for 3 hours. What it means is that if I am coughing or getting a neb treatment, or someone does some procedure that makes me aerosolize particles, it could be up to 3 hours. On copper, up to 4, on cardboard, up to 24 hours. So I see a lot of people who say, I'm just leaving my Amazon boxes out on the porch for 4 days. Probably one's okay if you really are that concerned about it. On plastic, 2 or 3 days, which is concerning. On stainless steel, 2 or 3 days. And this is done by a study in the New England Journal of Medicine by the University of California. So the other thing is, the confounder is that with this aerosolization, they use the nebulizer and not an actual cough. Not all coughs are equal, and so some people with a cough that's very mild may not aerosolize at all. Other people with a very aggressive back of the throat deep cough might create a lot of aerosolization. Why this is important to you is that the plastic bags that you take home from Martin's or things like that, maybe you don't want to take into your house. Maybe you want to clean them off. Maybe you want to just be cautious about them, put where you put them. I don't want you to worry about it, but this does show you that the virus does last longer on certain surfaces than others. This is an R naught, and this might be hard to see, and I apologize. This is the R naught of every state in the United States as of yesterday. And if you look, this is 1. This is the line that we're worried about. You say, well, Matt, why do I care about an R naught of 1? Because R naught is the magic number at 1 that if it's below 1, an outbreak will die off. Because that means if you have an R naught less than 1, that each person who is sick is making less than 1 person sick. You're like, well, Matt, you just said a couple of slides ago that the R naught is somewhere between 1.5 and 3.5. That's if you don't do anything. That's if you just are sick and out not doing anything. This is the effect of social distancing. This is the power of changing density of people, and good hand hygiene and mask hygiene has made all these numbers were much higher. And what this shows is that by actively doing all the things that the CDC and Dr. Fauci and your local ID doctors have asked you to do, you've pushed this number of infectivity under 1. Which means in a lot of states, if we continue to be really aggressive about wearing masks and social distancing, this will go away. If we don't, though, those numbers could creep up and again cause this outbreak to continue. You can see way over here, these 2 states have an R naught that's still just slightly above 1, but they're working on it as well. But I figure this is good news, and right now we could all use a little bit of good news. So number of new cases, as you can see, West Virginia, the number of new cases is slowly decreasing, but with the state of Virginia, they're currently increasing, and in the state of Maryland, they're kind of holding steady. Why is that important? Because state boundaries are imaginary lines. If I live in Martinsburg, I can drive to Winchester and no one's going to stop me, and back and forth. This is why, even though we should feel great about what we've done, we need to stay vigilant because not everybody's in the same situation. So this is a comparison of COVID-19 to other infectious disease. And what does it mean to you? This has got a lot of stuff, mortality rate and basic reproductive number, the R naught that we've talked so much about. If you look, COVID-19 sits right here. The R naught for other things are much higher. You can see that HIV, the R naught's about close to 4, diphtheria, it's close to 7, mumps, measles, way out there at the end, okay? But if you look at the mortality of these things, rabies, which has 100% mortality or close to it, tuberculosis, smallpox, MERS, the mortality rate is significantly lower than all these things. But the mortality rate of influenza is actually very, very low, seasonal influenza, pneumonia. So all this stuff that you're hearing about, flu kills more people, the flu kills more people because it gets a chance to. And the fact that it has such a low mortality rate and kills so many people means that we don't do a good job protecting ourselves from it, doing good social distancing, respiratory hygiene, vaccinations. COVID, its mortality rate is significantly higher. It's 4%, but versus 0.1, that's a huge exponential change in mortality. But look how much more infectious it is. So if we don't do anything, if we treat it the same way we do seasonal influenza, the numbers would be catastrophic. Do not be misled by people on Facebook who are trying to tell you that COVID is not something you need to worry about. It absolutely 100% is, okay? I'll tell you, I joke about Facebook all the time, and I say, unless you saw Facebook in your medical school class with you, don't trust anything that says in front of it. Now, the spread of COVID, as you see, this is a scenario that we came up with from a university where they talk about social distancing and how the reduction of social exposure actually reduces the R naught. And you see that if there's, in the scenario of no social distancing, one person infects 2.5 other people, in 30 days, 406 people are sick. If you have a 50% social reduction, that person infects 1.25 and there's 15 others. If you have a 75% reduction in social exposure, one person only infects 0.62, which is, it's about 1-to-1. These, in the small numbers, they don't help because you can't have 0.62 of a person. But at the 30-day period, it definitely is. This is still a growth. We really have to be aggressive. No social distancing means that a lot of people will get sick. Now, there comes a point in an epidemic where a lot of people who are sick are past their infectious period. They're not able to viral replicate any longer, and so that they're not making people sick. But we don't know if we're there yet, because we're still seeing new cases every day. And as long as there are new cases, these people are still infectious. So the situation where our numbers are dropping drastically, if we don't all do our part, we could end up right back here in a month. This is what I want to tell you about. This is the Spanish flu of 1918. The first cases were reported in September of 1918 in Philadelphia, and the United States was like, it's just a flu, don't worry about it. And as you can see, social distancing didn't happen for almost a month. But by that time, the virus already had a grip on the population, and literally hundreds of thousands of people were killed in the United States alone, and possibly millions. We don't know because the data was not great. As you can see, it took all the way from into December before we really saw a change in Philadelphia. But if you look at St. Louis, they enacted social distancing as soon as they noticed it. And the curve was longer, they were still spreading it, but there were less deaths. So yeah, Philadelphia got over it really quickly, but so many more people died than in St. Louis. And that's what you're experiencing now. If we'd have done nothing in the early part of the epidemic in the United States, it would probably be over by now. But hundreds of thousands of people would have died. What we're doing is flattening the curve. Well, when you flatten a curve, you just don't make it go away. You have to spread the area out. I want you to look at this picture. This is what happens when we don't follow social distancing. This is what happens when we don't respect the power of an infectious disease. These are wards of influenza patients who are dying because there was nothing we could do for them. So what can you do? How can you be a responsible West Virginian or a citizen of whatever state you're in? Wash your hands, wear a mask. So let's talk about masks. Everybody has an opinion on a mask. What mask do you need? Do I need a paper mask? Do I need a cloth mask? Do I need an N95? For the most average person out there, there's a couple things working in your favor. One, there's a low density of the virus right now. So the masks that you're wearing are actually to keep, if everyone wears a mask, it keeps people from infecting others. The efficacy of a mask is, one, to protect you, but also to protect everybody else. If you're sick and you don't know that you're sick yet, but you're wearing a mask, you're keeping those particles from infecting other people. What you need to do is wash your hands before you put on a mask, wear it the same way every time. It needs to cover your mouth and your nose. I see a lot of people just wearing it over your mouth. Unless you're an obligate mouth breather, you're still gonna have some entrance to your nose. Don't touch it. As we all know, I love to touch my face for whatever reason, but don't touch your mask either. If you do, wash your hands immediately. Don't remove your mask to talk to other people. That kind of defeats the purpose. Do not wear dirty masks in between use. When you take it off out and away from your face. Wash your hands immediately, put it in a plastic bag, and then wash it in hot water and then completely dry. So that's why it's helpful to have a couple of masks. If these are cloth masks, you want to have 3 or 4 so that you don't end up just washing the same mask over and over. Right now, my advice to you as a doctor and as an infectious disease doctor is to wear a mask all the time. And you say, well, Matt, you're not wearing one right now. Well, I'm trying to give a lecture and it's a little bit hard for you to understand me if I have a mask on. But also, I'm in a room where I'm not close to anybody. I'm not saying you have to wear a mask alone while you're in your car driving down the road. That's not at all what I'm saying. But if you're around people, you should absolutely wear a mask. You're like, well, Matt, that's so painful. I hate to think about it. It's uncomfortable. I know, but we all need to make sacrifices in this time to make sure that we're getting people the best chances of staying healthy. Remember, it's like the flu. If you get the flu, it might not kill you, but how many people might you make sick that could die from it? Vaccines. This is what everyone really wants to know. When are we going to get a vaccine so that life can go back to normal? Well, it's maybe closer than we think. There are more than 100 projects around the world centered on a development of a vaccine for the coronavirus. As of May 11th, 8 of them were being tested in clinical trials on humans. This is a huge deal. Our government enacted something called Project Warp Drive, or Warp Speed, depending on which one you read. And what that means is that we're jumping through a lot of the hoops and cutting through a lot of the red tape to get vaccines prepared sooner rather than later. And the vaccines that are in, some of the most promising vaccines that are in development, there's one by Moderna, and it began its mRNA messenger vaccine in trial 1 in Seattle, Washington. And they had already developed other mRNA, which is messenger RNA vaccines. That's the genetic information that tells the virus how to take over cells earlier. And so the platform is safe, which allowed them to skip certain animal testings. And it's expected to enter phase 3 trials in early summer. This is huge. This means that as early as December or January, this vaccine might be ready for public consumption. Inovio is another one. When it appeared in 2019, the company had been already working on a DNA vaccine for MERS, which is a similar coronavirus, which allowed the company to develop a potential vaccine targeting one of the similar proteins. It announced at the end of April that it had already enrolled 40 healthy volunteers in this clinical 1 trial, and it's set to start its clinical phase 2-3 trials later this summer. This is usually a process that takes years. And it shows how the dedication of our government to getting people a vaccine is really moving forward, because we're moving these vaccines ahead, cutting a lot of the bureaucracy out of it. But then you say to me, Matt, that means it's probably not safe, right? If you don't do years and years of testing on a vaccine, how do we know that it's safe? And the truth is, I'll be honest with you, a lot of vaccines take a lot of time to develop because there's a lot of redundancy in science and medicine. We need to make sure it's safe. We need to make sure it's effective. We need to make sure that it doesn't cause side effects. We need to make sure that patents are involved and things like that. Everyone is putting aside all these differences to get a vaccine to save people sooner rather than later. So this does not mean that just because these are moving forward quickly that they're going to be unsafe. The University of Oxford in England had over 500 participants in late April. They have a potential vaccine, an 80% chance of success that could be available as early as September. This would be a game changer because there's a very good chance that COVID might rear its ugly head again in the fall. And we want to make sure if it does, we have a vaccine. The vaccine uses a modified virus to trigger the immune system. It's partnered with AstraZeneca, which is a large pharmaceutical company. And mid-May, this vaccine was effective against COVID-19 after it was given to 6 rhesus macaque monkeys. They will be late-stage clinical trials by the middle of this year. But really, early as September, there could be a vaccine. Pharmaceutical companies Johnson & Johnson and Santa Fe are both working on their own vaccine. Pfizer is also working with a German company to develop a vaccine. These clinical trials began in late April, and they started their human testing in the United States in May. So things are happening. Why do I tell you this? Number one, I want to give you some hope. I want to give you some good news. But also I want to encourage you, this is the reason we need to continue social distancing and good hand hygiene and good respiratory hygiene. Because if we can hold out long enough, we can prevent another 1918 influenza pandemic. Until then, let's talk about treatment. There's a lot of controversy about treatment. I want you to know that as of today, there is no approved FDA medicine that is specifically for the treatment of COVID-19. There are a lot of medicines that we're using off-label use. The first one and the most promising is remdesivir. It is an antiviral that is used for the treatment of COVID-19 in patients who are very ill. It's not approved. However, it's being used through kind of compassionate use, which means the drug company says, we think it has an effect, and the FDA says, okay, we'll allow people to use it. We're not told to use it in mild to moderate cases, and so this is really a last-ditch attempt to save people who are in the ICU who are very sick from getting worse. Hydroxychloroquine and chloroquine. At the risk of getting things thrown at me through the screen, there is no evidence clinically that supports that hydroxychloroquine is effective and safe for the management of COVID-19. Literally, as I was walking over here to film this, I got a little newsfeed pop up on my phone that said the president has started taking hydroxychloroquine. So you say, well, Matt, if it's good enough for the president, it's good enough for me. And I'll say, okay, but check your science. One of the maxims of science is trust but verify. And so hydroxychloroquine, there's a lot of little studies that show some efficacy. These are called anecdotal evidence. There is no official treatment for COVID-19 endorsed for hydroxychloroquine. Immune-based therapies, convalescent plasma and immunoglobulins, these are blood products that are taken from people who have successfully survived and cleared their virus. And there's insufficient data. Just because they're human products, it takes a lot of people to produce enough to give to a person. So there's not a lot of it out there because, number one, we're just starting to see the large enough numbers of people who can donate plasma to help. And so there's some back and forth on the science. The other thing is there's also insufficient data to recommend the use of telecizumab or Actemra. You'll hear a lot of that going on. It's autoimmune drug that's become very popular right now. Again, there is no sufficient data to support that Actemra makes a difference. Why do I tell you that? It's because I don't want you to hang your hat on the fact that if I get sick, I don't need to worry about getting sick, because if I get sick, I can just take a medicine. That might not be true. In the history of mankind's relationship with viruses, there are very little treatments that work against viruses, and you have to trust your immune system. The newer a virus is, the less likely that any immune system has seen it and been able to conquer it, and the more rocky the relationship between the virus and the host is. So, common questions. Can it be spread through an HVAC system in a building? I guess nothing in life is certain but death and taxes, and only one of those. But it would be extremely unlikely that HVAC would allow the virus to transmit through a building. You say, well, Matt, hospitals use special rooms to make sure that the air is pumped out so that they don't affect other people. Yeah, that's true. But remember, hospitals are held to a higher level of epidemiology than normal basic science. And also to the efficacy of these particles to infect people after they travel a long period of time is just not been proven. The other question is, what do we know about coronavirus that we didn't know when this first began? Well, I think I covered a lot of that. We do know that we're starting to see that it is infecting children. We did not think that at first. We think that's a reporting error from China. We do know that it's causing an inflammatory syndrome in a lot of patients. And most of the patients that we're seeing who are young that are getting sick, if they get more than just a light cold, they're getting a disease-like process like Kawasaki's or an inflammatory process. We're seeing that people can have blood clots, increased risk of blood clots if they've had this infection. We're seeing that people who have been really sick with it, who survive, can have short-term and long-term memory problems. Our understanding of the virus is evolving. Very rarely in history have we ever taken such an active role in about finding out so much about a virus in such a short period of time. And I'm sure that we'll continue to learn much more about this. There's some evidence out there that shows that depending on what blood type you have, you might be more likely to get it or get sick from it. That's still under advisement. There's some studies that show that based on certain labs that you get when you get sick very early on, we can predict whether or not you're going to get really sick. And the next couple of months will be very exciting and scary as we find out more and more about this virus. So you're going to have to pay attention to what's out there, look at the resources that you have, make sure that you're vetting your resources. Remember, everything that you see online is not necessarily true. Anybody can go online and write anything and no one's going to stop them. You have to make sure that you're using good resources, and I've talked about this in every lecture that I ever give, using the CDC, the World Health Organization, the National Institute of Allergy and Immunology. And you say, well, Matt, even the president thinks that the World Health Organization didn't do a good job. Politics aside, the science of the World Health Organization has historically been proven to be very concrete and appropriate. Remember, most of us are not politicians. So we leave the politics to politicians, just like we leave the medicine to doctors, the baking to bakers, the nursing to nurses, and the teaching to teachers. Set the politics aside and look at the science. If the science is sound, then you can't argue with science. Gravity is gravity every day of the week. What are coronavirus toes, and why doesn't this virus affect the toes when something else doesn't? Or does flu do something like this? The coronavirus toes that you're seeing are probably another vascular manifestation, and as we learn more about how this virus interacts with red blood cells and virus and veins and arteries, we'll see more about vasculature come out. We're going to learn a lot about virology in the next couple of months, and this is going to be a painful but exciting time in science. That's the end, but not really. We all know that this isn't over. We know that while we've done a lot in a really short period of time and we've made some really good headway, we still need to focus on the fact that we're all in this together. Just because social distancing is being released by the state doesn't mean that you have to run out and do everything that you would have done normally. The world is not going to be the same as it was for a very long time, maybe ever. That doesn't mean that you have to be sad or give up hope, but it does mean that you need to be aware of the things that you need to do to keep yourself and the people that you love safe. Wearing a mask is a pain. I know. I carry several around with me all the time, and even at times I need to be reminded to put a mask on. That's where we're all in this together. Everybody make sure that everybody's doing their part. But together, we got this far, and we've done a really good job. We need to stick together with that spirit of the mountaineer and look out for one another and take care of one another like we always have. I will continue to be here with you to answer your questions, to help you through the hard parts and celebrate the good parts. But until then, wear your mask, wash your hands. We'll see you soon.